Good evening, everyone, and welcome to my monthly pre-hospital webinar. And it's quite appropriate after spending the last 2 days teaching airway stuff to paramedics that we're going to talk about something airway related. So I'm well warmed up on the subject, having been teaching this subject first thing this morning. So that was a good warm up. As usual, as Andy said, we've got the chat thing open for general comms, but if you've got any questions, please separate them and put them in the Q&A box because that enables me to pick them out at the end, and we should have some time for some questions. So we're going to go ahead and discuss what's at the top of the airway ladder. I like this picture I found in PowerPoint. Do you like the way I put the logo in there, Andy? You impressed by that?
I've never seen one of them in an airway, Jamie.
Well, there you go. That's what. See what you know. Okay, so what's at the top of the airway ladder? The good there, I suppose it's not good news. Yeah, if we've found our way there, then we're generally having a bad day, though not as bad day as the patient is. Yeah, so it's never going to be good news. So either our airway things weren't going to be of any use if we've done some airway prediction, but we've used all our airway things and the patient is still trying to be dead, in which case we're faced by doing something else, and that's going to be a problem. So I think it's important, as with everything, if you listen to people's talks and let people teach you stuff and that sort of thing, that people have a good understanding of the thing they're teaching and they actually do it. So yeah, all this stuff is within my scope of practice and is things that I have actually done. So what's the issue? Yeah, sort of a patient with a totally obstructed airway. And we might think about some sort of causes for that. So those of you got the chat open, yeah, go for it. What sort of in the chat, what sort of causes might we have a totally obstructed airway in a pre-hospital patient? Go. Come on, chat. Yes, I've just seen Simon here. Yeah, well done, Simon. Yeah, so facial trauma, absolutely. Yeah, so particularly a massive facial destruction, lots of bleeding or just mush. Blockage, as in, yeah, and there's a shared one there, foreign body, basically. So foreign body airway obstruction, we've been unable to resolve doing other things. That's probably one of the most common burns, particularly inhalational burns, or possibly, extensive burns to the face and neck. Massive wild anaphylaxis, the patients who attempt to die in 60 seconds. But yeah, quite commonly food boluses or other trauma. Certainly we've seen some recently with hangings and that sort of thing, where there's been trauma to the larynx. So yeah, I think we picked most of those up there. Possibly infection. Yeah, that's a good one. People have got massive infection. I remember seeing a guy when I was working in the out-of-hours GPs who couldn't speak, and he was gesturing at his mouth, and I think he managed to sort of croak the words tonsillitis. And I got him to open his mouth. I'm not joking. I think this man had actually swallowed 2 cricket balls. I've never seen tonsils like it. I just couldn't believe he was actually alive. Yeah, he didn't seem to have any airway left at all. So that's another good one. Yeah, yeah, massive trauma. Oh yeah, so possibly, yeah, people who have inhaled something nasty. Also, I was discussing this with the students this morning. We thought about things like people who have drunk stuff, really caustic stuff like caustic soda, acids, that sort of thing that could cause, massive internal burns and swelling all at the same time. Yeah, so any of those sort of things. Yeah, so I think we've got all those things on my list, along with possibly position, so patient or airway. So someone who's trapped somewhere and who can't get to their airway by traditional means, that could be another one. Yeah, if someone's trapped in a position and with no airway in the place, you can access their neck. Yeah, and sometimes just some patients. You look at some of the sort of case studies of patients that end up with surgical airways, and no one really knows sometimes why they ended up with a surgical airway. They don't know the reason why. They just know that for some reason they couldn't get an airway, and this patient couldn't ventilate them, etc. So something had to happen to save the patient's life. We know this is time sensitive. Yeah, we know that, in a patient with no airway, it's high in our ALS algorithm, high in our primary survey, because if a patient has an occluded airway, they're going to be suffering sort of hypoxic related neurological damage. And if we can't get an airway at all, that's probably going to make most other interventions futile. Yeah, it doesn't matter how many chest compressions or how much adrenaline you give someone in cardiac arrest. If they have zero airway and nothing changes, then that's going nowhere. And then some of the things we have to consider is, well, what does that time mean for these patients? Yeah, why is that relevant? And I think we have to accept that, 99.999% recurring forever of 999 calls are answered, by a dual crewed ambulance. That's the default position. Yeah. So, and the chance of the dispatch of higher clinical support is affected by call identification, something I know which is a lot of study going into because it's actually quite difficult. We know that the triage systems we use are over safe when it comes to people that haven't got much wrong with them, but are also quite poor at identifying the more subtle, seriously unwell people, because that requires some clinical acumen to pick up the triggers that you can't put into yes and no triage questions. And certainly that's some of the things we pick out when we look at calls that are pending and go, oh yeah, that might be quite a low category, but there's words in there I don't like. Yeah, from my experience. Also, time of day or week and location. Yeah, so the availability of some form of enhanced or critical or care or higher clinical level support, someone who has a larger scope, skill set, or experience, is very much affected by time of day or week, the geographical location you're in, the weather, and lots of other stuff. And we know currently, as a whole across the UK, the response times for ambulances are varying up and down, but are generally at the worst level they've been for a number of years. We've had really bad spells where Cat 1 and Cat 2 response times have been, so we say, suboptimal. And we also have to remember that the patient's hypoxia happened at the point of obstruction, not at the point of call or the point of ambulance arrival. Their clock, the patient's clock, starts at the start of symptoms. And sometimes it's a time we don't necessarily record that well. In the times we record, we know the time of call, the time of dispatch, the time, we arrived on scene, and maybe the time we arrived at the patient, which could be some time later. But time of actually onset of symptoms, in this case, time of airway obstruction, is very relevant, isn't it? And that's something that is always immediately available. How long was it while they recognized the patient had difficulty, or the patient, airway obstructed and someone got help and they had no phone signal, and all these things. So we know that time is very, very relevant to these patients and what happens to them. And we're going to assume, here's one for the older generation, Simon. We're going to assume that, there's going to be a paramedic on the ambulance. Yeah, so our immediate skill set arrival will be a paramedic. Yeah, and but now, with the issues in the UK of retention of healthcare professionals and registrants within frontline ambulance services, that could be a AAP or ECA, and so a sort of a advanced life support level response may be further away than ever before, as we struggle to sort of maintain an ALS level workforce. So how are we ending up, at this position? Yeah, and that, have we identified an airway problem, then worked our way down the airway ladder, which isn't a phrase I particularly like because it suggests that everything comes in steps. Whereas in reality, we might leap a load of those steps because we may arrive at a patient and go, nothing else is going to work, using our tool of prediction, based on my experience and based on my knowledge of these devices. If you open the patient's mouth and there is clearly no airway at all, there's no hole to stick something in, then, an IGL is probably not going to be of much use for you. So we can forget that step and so on. So we can work our way through either trying things or ruling things out intentionally on the basis we don't think they're going to work, and therefore we're wasting the patient's time in doing something that's very unlikely to work. So we're looking at our evidence-based practice here, best available evidence, our professional expertise, patient's preferences and values, which in this case as a whole would be the patient would rather have an airway. And then we have to add in the other things about resources, legal aspects, culture, etc. The bigger picture of our sort of evidence-based practice. But you really need to accelerate this process. You really need those skills of airway prediction, and experience of devices, and also not to prolong that hypoxia by repeatedly trying interventions that are very unlikely to succeed, and have the ability to move on. The ability to say that this device has failed, this device does not work. And what we have there is, although it's very strong in the language, what we have there is not a failed airway. Failed airway only happens when you've tried everything and nothing has worked. What you have is a failed procedure. Although failed airway is quite strong in the sort of vernacular used for some of this decision-making stuff. So then we need to have a plan. What is our plan? If we don't have an airway and we've tried our clever things and none of that's worked, what is our plan? And so having a plan enables us to, in some form of guideline, and guidelines drive us towards sensible decision-making. They're not a protocol. They're not absolute. We don't have to do the steps, but they take us in the right direction and try and minimize adverse outcomes. So, have we really tried to mass ventilate the patient well using our BVM? Or did we just try it a bit? Is the patient's airways actually really fully obstructed, or can you ventilate a little bit? And if you think you can you do better BVM? Is there things you can do to improve that? Be it two-handed grip or adjuncts or positioning, ramping, intersternal notch, etc. Anything we can do to improve airflow is the stuff we can do to buy ourselves time. If the instruction is further down and we could place an iGel, have we tried it? Because, I don't think, absolutely we'd rule everything out. We might not think it's going to work, but sometimes you just never know. So have we tried something and then ruled it out to see if it works? And if none of that works, then that should be driving us towards some form of intervention through the cricothyroid membrane, generically termed as front of neck access, became a sort of popular term. I'm not a huge fan of the term front of neck access because it doesn't sound very important. It sounds like some sort of fire exit or something that doesn't seem quite so critical. I prefer terms like emergency surgical airway or something like that, because it defines how important it is, how you're going to do it, and what it is you're trying to achieve an airway. Although I recognize that front of neck access is a broader term that encompasses many techniques, but I don't think it's very descriptive. And I think language is important in what we do. It's quite important that we use language that places value on stuff. That's a theme I sort of bring up again and again, if you're brave enough to listen to more than one of my talks. What does JL-Calc say? And something we can't pretend it doesn't exist. It is our national guidelines for pre-hospital care. And, is a guideline at that, but, it's quite a strong influencer in what happens in UK ambulance services. Well, unsurprisingly, JL-Calc is quite contradictory, having had a good look through in the airway sections and things that can lead to airway sections like airway obstruction. In the airway algorithm, it says that if you've run out of stuff, you should do a needle cricothyroidotomy. But in the choking algorithm, it says you should do a needle cric or an emergency surgical airway if trained or authorized. So I'm not quite sure one algorithm says one thing or one algorithm says another. But it does define that both procedures are available if you're trained appropriately. So what about anatomy? We have to remember what it is we're trying to achieve. What we're trying to achieve is a cricothyroidotomy, not a tracheotomy. And sometimes when we're talking to staff that work in different settings, they're like, we wouldn't do a tracheostomy, that's really dangerous. And absolutely, to cut into the trachea is often only done by sort of ENT surgeons in a very slow, methodical way, because either side of there you have major blood vessels. And if you hit one of the major blood vessels, there's going to be a lot of mess and a lot of paperwork. So, it's a very different thing. Yeah, we have to be careful. We're talking about the same thing. So our cricothyroidotomy, going through the cricothyroid membrane, is in a much safer place. Yeah, and I think that's important to recognize. So we've marked there our cricothyroid membrane, below our laryngeal prominence between the thyroid cartilage and the cricoid cartilage. You have to remember we don't end up too high in the thyroid membrane. If you feel up above your laryngeal prominence, you'll feel another fairly similar slot that it's possible to go through and insert some form of device for you below the hyoid bone. Trouble with that is you're going to end up approximately at or above the vocal cords. And so if this is an obstruction, it's not going to work, and you're probably not going to get a tube in there. So we need to make sure we're in the right position. So below the laryngeal prominence, and a good definition is sort of in the lower third of the neck. If you're down in that region, you've probably found the right thing. But that is going to affect identification. Is going to be based on patient groups. As to which group's easier to find the landmarks and which group's harder. So, here comes some of that pesky evidence-based practice again. So we'd like to dig out some evidence and look at a review of, what works and what doesn't if we're going to perform some form of front of neck access. So the first thing we consider is needle cricothyroidotomy, the procedure that's available to most UK paramedics. But it comes with some problems. Firstly, it defies an MHRA ruling about the use of medical devices. What most places will use is an IV cannula, and the use of an IV cannula for anything other than sticking it in an IV has not been tested by the manufacturer, and the device isn't approved for that. So whoever guides that will assume, not the operator necessarily, if it's been guided to do, but will assume the responsibility for that and for it failing or working or any side effects, because the manufacturer would never say, yep, it's fine to stick our IV cannulas in someone's neck. We're quite happy with that. So that's never going to happen. And I think that, as a procedure, it's quite hard to clinically justify when there are better options, but that's an issue for whoever provides your governance. Second problem really is, can you breathe through an IV cannula? Can someone ventilate themselves through an IV cannula? Yeah, it's way too small, isn't it? Even trying to breathe through a drinking straw is pretty much impossible. Although, of course, like asthmatics and others with narrow airways, people are able to generally get air in, but struggle to get air out of these narrow airways, and that would apply through a narrow artificial airway like an IV cannula as well. And that, of course, is because breathing in is active. We have muscles, our diaphragm moves, our intercostals move, etc., and give us active inhalation, whereas exhalation is mostly passive. So while we can pull air in through narrow tubes or put air in under pressure, it won't come out because the same pressure isn't there and the drive isn't there. The other issue is the IV cannula might actually just kink and fail. IV cannulas are very, very weak and not designed to be kinked unless they're stuck down really well. And that doesn't really work when they're stuck in someone's neck. The flow is very much limited by the cannula size, and you can look up the flow size of cannulas. And it gives you there an idea of how many mils you can move a minute in liquid. So I'm not sure how that relates to how many mils you can move of high pressure gas, but the cannula size doesn't get any bigger, so that's really going to affect that. It's rare to find equipment for doing this. It's rare to find a made kit for doing a needle cricothyroidotomy. It's generally a bodge of things that are found in the ambulance. I'm sure some places do have them, but otherwise you've got to find an IV cannula of an appropriate size. And the preference would be there may be a three-way tap because it's got the right fitting for the cannula and the oxygen tubing, which sticks on it really well, which you've got to scavenge out of an oxygen mask. And we know this will at best provide oxygenation. Yeah, so we can blow some high pressure oxygen in with oxygen at 15 liters a minute. It's definitely not ventilation. There's probably not going to be any exhalation. Yeah, because exhalation being passive. It's going to form some gas trapping then. The chest is probably going to get bigger and bigger if we're blowing high pressure oxygen in. And that's going to lead to requiring some manual decompression of us squeezing the chest to empty some of that gas out and then start again. And that's probably also going to affect cardiac output. So if this patient is hemodynamically unstable, having a high intrathoracic pressure from using high flow oxygen to oxygenate the patient is not going to help their cardiac output because they're not ventilating properly. We know that massively affects people's hemodynamic status. Yeah, we hear and see all sorts of weird stuff about needle cric. Like bodging bits of syringes and ET adapters together so you can fit a BVM on the end of it, which then will just allow you to squeeze the BVM once, then they'll be full of gas, and they still won't exhale. Yeah, so it's just going to accelerate the gas trapping without providing ventilation, because squeezing gas in isn't going to help if you can't get gas out. And sticking in extra cannulas into the neck to allow exhalation, I really don't think that's going to provide any benefit either, because it's just no pressure behind that exhalation. So you hear some really weird stuff. But it can be a successful technique in the right setting. Yeah. It happens in specialist anesthetic settings where a patient, for some reason, can't have any form of airway tube in the oral cavity. So they're having complex oral surgery or they've got to operate in the top of the glottic opening or something like that and can't do anything else. Then you can do transtracheal ventilation. You can ventilate someone through the cricothyroid membrane, and there is both reusable and disposable kits for doing that have purpose-made custom cannulas of a decent size, but most importantly, a specific valve designed to deliver high-pressure oxygen flow, but then also suction. Yeah, so they then provide the reverse to suck gas out. Yeah, so transtracheal ventilation can work if you have the right kit, which pre-hospitally I don't think we do. The Ventrain is a disposable kit, the one to the right, but I'm not aware of anywhere that's using it pre-hospitally, but I'd be interested to see if anyone is. And you look into the evidence base for these procedures, and there's some really good papers out there around surgical airways, and I've got a list right at the end for you. The evidence suggests that that a needle cric may have a approximately 80% procedural success rate, which isn't a surprise. It's not that difficult to get a very small trachea into the much very small cannula into the much larger trachea. Getting the needle in there isn't the problem. The problem is then trying to ventilate or oxygenate someone through a very tiny cannula. So it's not recommended in most guidelines. But if you're talking about pediatrics, depending on your local guideline, under 8 or maybe under 12, the surgical procedure, a scalpel-based surgical procedure, becomes more difficult. And you need smaller equipment, or it may be impossible at all because you can't identify the cricothyroid membrane. And so a needle procedure probably is it. Yeah, and you're going to do it because it's all you've got. So you won't really find many guidelines that guide the use of needle cric in adults. Yeah, in the UK, other than JR Calc. Yeah, most actually go as far as saying don't do it. Yeah, because it doesn't work and there's better alternatives. Interestingly, in Southwest Ambulance Service in the UK, the needle cric has been removed as a procedure. Yeah, I think on the basis that it provides little benefit and people spend time worrying about doing needle crics that probably don't help, when in fact they could be probably trying to either use something else like back mass ventilation if it's not total airway obstruction, or getting someone to the patient to help, or getting the patient to someone who can help. yeah, rather than sticking cannulas in their neck. Yeah, so that's probably something that's may come to other places. I know someone saying some of the ambulance services in the Netherlands use the Ventrain. Yeah, I think I was aware of that, and I think it might be the device might come from the Netherlands. I think, and certainly we had to go with one years ago, and it seemed to work really well. So we're going to say needle crike, probably not a great idea. If it's all we've got, well, you're probably going to try it because who knows? Yeah, but certainly the evidence doesn't suggest it being a good idea. So what next? Yeah, what is the middle ground? The middle ground is some form of surgical airway device. And there's about 5 or 6 manufacturers that over time have made these surgical airway devices. And this is one of the more common ones that you find around. But as a whole, they're all follow the same sort of principle. They're a very large curved needle as a whole with a short cuffed ET tube over the top, usually about a 6 mil ET tube over the top. And they're made to be pushed through the cricothyroid membrane. Seems like a good idea. Yeah, we want to do a procedure, and someone has gone and made devices to do that procedure. And that seems like a good thing. And the device is approved for that. The device is made for that. It's been tested for that. So this seems like a good thing. But across all the devices, there are some issues. Yeah, and all the studies into the devices show pretty much the same. A quite prolonged procedure time. Certainly for the most common device, the average procedure time was about 4.5 minutes. Now, that's because the devices are quite complex. They're well packaged, and there's all sorts of weird colored tabs and things you've got to pull off. And then if the last time you trained on it was 2 years ago, you've then got to quickly remember how to use it. Yeah, so the device itself can be quite complex. A common failure point is failure to insert. They just don't go in. And false passage is quite common. Most of them don't have a way of knowing you're actually in. You push the device in through the cricothyroid membrane, but you don't actually know where it is until you connect your BVM to the short cuff tube, squeeze it, and see it whether their lungs inflate or their neck inflates. Obviously, the first one being preferable. And the tube that's there is quite short. Yeah, so if the person has some form of cause of airway obstruction like burns or anaphylaxis and they continue to swell around the neck, then it could pull the tube back out. But one of the most common failure points is getting the thing in. Yeah, they're quite a large, bulky device. And in adults, the cricothyroid membrane is only usually about 9 to 11 millimeters in height. So you're trying to get this quite big thing in an awkward place through a very small hole that in some patients is very difficult to identify. There is a study been done somewhere where they looked at identifying the cricothyroid membrane in a wide group of patients. And they got people to, on real patients, sort of identify where they thought the cricothyroid membrane was, and then they ultrasounded the patients afterwards to identify where it really was, and then looked at the results. And let's just say they weren't great. Yeah, I think the correct the rate of being correct about where the cricothyroid membrane was somewhere around 50%. Yeah, so it depended which technique you use to find the cricothyroid membrane, but the rate can be quite low. So if you're struggling to find the cricothyroid membrane, if you can't find where to stick this device, then there's not really any use for the device at all. It becomes what is a very expensive doorstop. Yeah, because you have to know where the membrane is to be able to put the thing in. And the cricothyroid membrane is quite fibrous, it's quite tough. And so sometimes if you've only got a small membrane, you've got to use quite a lot of force to get these devices in. And that can lead to the device going through the back of the larynx and into the esophagus, which again is obviously not ideal. So across the studies into the device, success rates were reported somewhere around 50%. They work really well on the simulator the manufacturer gives for them, oddly enough. But in real patients, the success rate was somewhere around 50%, with failure to insert being one of the most common points of failure. Just can't get the thing in, or you end up in false passage. Quite high complication rates, long insertion times, poor skill retention because of all the tabs and things and which way around does it go and all that sort of stuff, and they're quite expensive. Some places still have them, and some places remove them. The military certainly used to use them, and they got rid of them. CCAM had them, got rid of them. But I know some places like Wales still have them. And in our sort of extra rural ambulance services particularly, then you have to have a slightly different mindset about procedural scope, particularly where there may not be help available for a very long time. So as a whole, I wouldn't say they're a recommended device. There's a lot of, in all the studies of them, there's a lot of complications. Now you could argue that 50% is better than no percent, and absolutely I would agree with that. If it works 50% of the time, I guess 50% that's better than no percent of the time. But if someone came to you with a device to sell it to you and said it only worked 50% of the time, we might not buy it. So in most medical stuff, our key marker for something being good is 90%. There's very little 100% in medicine, so the 90% is 100%. If something can be 90% successful or near to there, that's a good procedural thing. There is complications. So where do we end up at the end of this line? We end up with a scalpel-based emergency surgical airway. This is the thing that's most widely taught. It's simple and it uses familiar equipment. In adult cases, an adult bougie, which is 15 French gauge in diameter. In French gauge means this is external diameter, so that's 5 mils. Which is a standard adult bougie size, and easily available. A 6 mil cuff DT tube, and that's because a 6 mil tube is 6 mils on the inside, so it'll fit over a 5 mil bougie. You couldn't use a 5 mil tube because that won't fit. So a 6 mil tube will fit over the 5 mil bougie. So it's the smallest size tube we can use with an adult bougie. It's also universally available, 6 mil tubes in most adult airway kits. But a 6 mil tube is also 8 to 8.5 mils on the outside. And we said the cricothyroid membrane analysis is only 9 to 11 mils. That's probably also the biggest tube we can get in. So it's universally the smallest one we can use and the biggest one we can use. And luckily it's one that's easily available. So familiar equipment. The only thing that's really unfamiliar is the scalpel. So easy to teach. This is something we created a while back and is in use in a lot of places. Our surgical airway kits are used in a lot of sporting venues. It's used by so these cards are available to some people I can see online that use it as well. So we created a simple guide with the pictorial reference. This is not for the user. This is for your airway assistant. A surgical airway should be a 2-person procedure like an intubation. This needs someone to read this out to you as a reminder of what's gone on. It's a relatively simple procedure to teach. We use expensive custom-made tissue trainers. We've tried all the plastic ones, and they're pretty awful. They have no feel. Once you cut it, it's cut, and that's it. And you stick tape over it or whatever. We've really not found a plastic one, despite trying lots that have the feel of the animal tissue ones we get. And it is a waste product, that part of the animal, but they are custom made for us, and they're very nice. It uses didactic steps with little muscle memory, unlike endotracheal intubation, which requires a large amount of experience to develop the muscle memory to do laryngoscopy, and then maintenance of that experience through continuous practice, through simulation or real patient use. This doesn't have that. It doesn't have a muscle memory skill. It has a set of procedures. It requires refreshers, but they're not significant. Yeah, in most systems that we've done work with, it's usually based around 6 monthly refreshers just to make sure people are still comfortable with the skill. Varying techniques are taught in different places. I see a couple of military people in the chat there. Yeah, and through battles they train team medics and above to use surgical cric kits. Yeah, and what they use is if I'm right, it's the purple and blue coloured Portex 6mm tracheostomy tube. Yeah, which wasn't a purpose-made device. It's a pediatric tracheostomy tube, 6mm tracheostomy tube. It was never made for what it was being used for, but it did work. But they became ludicrously expensive, and also they were quite short. So in our I think we can probably safely say that the military cohort for surgical airway is probably somewhat different than the civilian one, and they were probably quite short for our use. Yeah, but yeah, procedures taught were quite different. It also has no indicator for position. Yeah, and it's not good for our larger patients. We also avoid other stuff common used in tracheostomies. We try and avoid tracheal hooks, tracheal dilators, and other specialist ENT equipment, which are great if you're an ENT surgeon, but not the sort of thing you want to be using if you've never used them before and are not familiar with them. Yeah, if you're not a specialist surgeon, yeah, you want stuff you're familiar with and you want stuff that's simple. We've refined the technique we teach, looking at different practices and different experiences. Some places teach if you can identify the cricothyroid membrane to use a horizontal incision. Some places always teach to use a vertical incision. And we've generally switched now to teaching only vertical incision. If you want to do this once, you want to do it right. And our patient group doesn't tend to be easy patients. They're not young, thin males that you can see their cricothyroid membrane across the room. Yeah, ours are a more difficult patient group, and we want it to be right first time. So we teach a vertical midline incision followed by horizontal maneuver. Because a failed first attempt will complicate a second attempt, as well as greatly increasing your heart rate and your stress levels and so on. And we know at a time of stress, people are quite poor at making decisions. So trying to decide whether you can feel the cricothyroid membrane or not to do a horizontal or vertical incision probably isn't the best time to be doing that. We teach using a 6mm cuff DT tube and a standard adult bougie. And that is a sort of a standardized procedure. And the kit is packed with one of these sort of standardized cards as a reminder of the steps that you want to undertake. In the alive patient, because no one has said they had to be dead, yeah, there will be bleeding. Yeah, there'll be a significant amount of capillary bleeding, particularly with the vertical incision. And sometimes there can be a blood vessel that runs over the top of the larynx there, and it can bleed. But the patient is not going to bleed to death. Yeah, in the ones we've done where the patient has been in cardiac arrest, there's been almost no bleeding because, of course, there's no circulation. And that's why in our guide it says, this is a tactile procedure. Yeah, you use your hands, you use your fingers. Yeah, the bleeding doesn't matter. You don't need to visualize everything. This is the most widely recognized procedure. Variants of it, like the Difficult Airway Society guidelines and so on, recommend a scalpel-based technique. And scalpel-based kits are usually on every difficult airway trolley, ideally packed in a way that's easily identified, and quite commonly stuck or hung on the outside of the trolley, so they're very visually apparent as a reminder that they should be there and to use them. there's plenty of evidence, and it's all in the reference list I put at the end. Yeah, but there's a huge amount of evidence from the British military database from Afghanistan, large amounts of surgical airways, not necessarily due to airway obstruction, but for establishing a secure airway that can allow the unfortunate patient to be dragged across the ground for evacuation without having to do airway maintenance. But a very high success rate of 92% in British military surgical airways using a scalpel-based technique, admittedly with the Portex tracheostomy type tube as a whole. But given that's not as a whole healthcare professionals, some of those will be soldiers with extended medical training rather than CMTs or specialist units, and that's a very good success rate. And other studies from the UK, including those from Northwest Ambulance Service, where their APs had a 97% success rate. It's very cheap to introduce because it's just a disposable scalpel, which I think are about 17 pence for a size 10 scalpel. Easy skill retention and fast. So the NWAS study had a time of, I think, 57 seconds. So overall, if you look at the evidence, then this is the way. Someone's saying CMT and up can do front and neck. Okay. So who should be doing it? Yeah, so currently it's a skill, maintained by advanced paramedics, enhanced care paramedics, critical care paramedics, critical care teams, and other people in a higher clinical role. Yeah. And if we go right back to the very start of our talk, yeah, one of the issues is time, isn't it? Yeah, and we know that, if you're lucky, one of these units is close and can be there and provide that intervention. But commonly, depending on where you are in the UK and their availability and time of day and the weather and all the other things we discussed, they might be some distance away. And if that's the case, then you probably have no solution apart from to take the patient to that procedure. But again, that's going to take time in extracting the patient and taking them somewhere. And, in many smaller trauma units, it probably is sometimes that someone had done a surgical airway. Yeah. So, I think we have a time-based problem. So I think it's reasonable to suggest that with, a reasonable training package, some good governance, some refresher training, then a larger cohort of advanced life support providers at paramedic or equivalent level could safely perform a front of neck access scalpel-based emergency surgical airway. Because at the end of the day, if the patient has no airway, and even if you make that criteria, the patient's in cardiac arrest, which is a common paramedic criteria to make sure you can't make the patient worse, then you cannot make the patient worse. If the patient has no airway and they're in cardiac arrest, you can't make them any worse by doing a surgical airway on them. You only have the chance of making them better. You might make them look slightly less tidy, but you can't make them worse. Yeah, so I think there isn't necessarily a huge amount of risk there in the right circumstances. And even in paramedics now, which is more common across English trusts of them being non-intubators, yeah, it still could be a permitted skill and allows people a way out of where they have a airway they can't maintain, particularly in cardiac arrest. Now, I'm not saying that all things should be for everyone. There are many advanced practice things that can only be done safely by those with a necessary level of education and particularly experiential learning and reflection to allow them to safely practice those skills. But I'm not sure surgical airway is one of those things, and certainly other experiences, particularly from the military and so on, would suggest that. Now, this is only just here in case the CCPs are waiting for me outside for volunteering to give away one of their things. But I certainly think the evidence doesn't suggest that this should be entirely a specialist skill in the right circumstances. So finally, for those that have access to a very quick photo snap or a screenshot or are a premium member, like Andrew said earlier, then here is a list of the lots and lots of things about surgical airway, that you can find out about. Some good articles in there, particularly the ones by Kate Crudson and so on from London HEMS, where they were comparing lots of airway devices. There's some really good stuff in there about front of neck access. So thanks everyone as ever, for taking time to be with us this evening.